upper left-hand part of this slide, you'll see the relapsing remitting MS pattern. The relapse occurs, and it goes above the baseline, and then there's a remission, and the clinical symptoms go away, and they're at baseline. This may occur several times. Importantly, there is then a relapse and then a remission. But as the disease progresses, the patient starts to have accrued neurological deficit. On the upper right-hand side is the secondary progressive MS. This is the type of MS that we talked about that many people will go on to have. But they have a relapse, the patient remits to the baseline, they have another relapse, but from then on there is secondary progression of the MS and an increasing residual, and they climb that ladder of the EDSS. The bottom left part of this slide shows the primary progressive MS, which I'm not going to talk about much tonight since we don't really have a treatment for it, but they gradually increase their residual aspects of their disease and they get more and more impairment. Progressive relapsing MS is where there is progression, but they have periods of a relapse, which occurs, and then they get a little better, but again, they have a significant increasing neurological findings. I'd like to review, before we start about clinical trials and treatment, the conventional MRI picture in MS and how we think about it. I'm not trying to make you radiologists, but what we need to know is some kind of concept about the MRI. Since it came about in 1983, here locally and other places, we've had a great advantage to look at the picture of MS on the MRI. In the upper left-hand corner, you'll see a MRI where the ventricles or the spinal fluid is white, and we call this a T2 lesion. And you can see the T2 lesions there around the juxtacortical region and around the ventricles. These are T2 lesions, which we'll talk about and are very important if they are present in increasing number. On the right-hand side, in the upper right-hand corner, we have a picture we call a T1 gadolinium post-contrast MRI. And when the patient has contrast and these lesions light up, there is evidence of a breakdown of the blood-brain barrier and there's active inflammation. This is an important concept and an important sign that there's active disease ongoing. The bottom picture shows us that this is T1 pre-contrast. And again, the spinal fluid in this looks dark. And what we have here is hypointense lesions. And we break that down into two important types of lesions. One is the acute hypointense lesion, and it looks like a dark hole. And about 50% of those will oftentimes resolve, and they may go away. They may turn into a T2 lesion. But many of them become chronic, and they're called chronic black holes. And when we have an increasing number of chronic black holes, it's strongly correlated with progression of disability in these patients. It also correlates well with cognition changes, and it represents the most important and most severe part of the axonal loss and significant changes that are occurring in the MRI. Now, this is the slide we talked about in phase 1, and it's the natural history of MS, and it's very important. It shows us 4 features of MS. This slide is orientated in a way which is very important, and on the left side we see preclinical aspect of MS, meaning the patient's not had any clinical features. Then we have the relapsing remitting part, and then we have the secondary progressive part. And through those 3 phases, we are measuring 4 important key factors. The white line is a measure of brain volume, and you can see in the preclinical phase, the brain volume is normal. In relapsing remitting, when there's activity and clinical symptoms, the brain volume starts to decrease. And in the secondary progressive, the brain volume decreases more. We call this cerebral atrophy. The blue line indicates relapses and impairment. So the patient in the preclinical phase has no relapses. But as we get into relapsing and remitting, you can see, again, there's a relapse. It goes up from the baseline, then with remission it comes down, it repeats itself. And in the secondary progressive, what happens is that there is fewer relapses, but there is significant accumulation of impairment. The red line is the MRI lesion accumulation, which we talked a little bit about. And that occurs early on, but as time goes on in relapsing remitting, there's greater burden, meaning more T2 lesions, more T1 hypointense lesions. And as you have secondary progressive, there's greater accumulation. And then the MRI activity is the yellow line, and you can see it's quite active. Preclinical, it definitely occurs in the relapsing remitting form, but then it kind of phases out or is less common in the more later part of the disease. This graph shows us that early relapses or more frequent relapses affect long-term disability, meaning that the more attacks you have in a certain period of time, the faster you progress. And in this slide, we see on the graph, on the left-hand side is a percent of patients. And on the bottom, or the horizontal, is the time from the onset of MS. And we can see here that what we're dealing with and describing is the percentage of patients not having reached DSS, or EDSS 6, which is impairment of walking or needing assistance. So what we look at is the yellow line, which says that there's only 0 to 1 attacks in 2 years. And we can see that it's shifted to the right, and that means that there is fewer patients that actually have reached the DSS 6. And they're fewer, and they go a longer period of time until they get that disability scale. But when you have 2 to 4 attacks, then more patients will have disability, or another way to look at it is those patients have not reached the DEDS of 6, but what we have is, in the green line, that there are more patients that will get that EDSS of 6, and they get it quicker in a shorter period of time. This graph shows us that early relapses, or more frequent relapses, affect long-term disability, meaning that the more attacks you have in a certain period of time, the faster you progress. Now, there are predictors of poor treatment response, and the one I'd like to discuss in this slide is that of new lesions on T2-weighted MRI. And we like to divide this up into responders to treatment and poor responders. Now, there are other things that really indicate that, such as a short time to a new relapse or gadolinium-enhancing lesions. But I want to focus on the number of T2 lesions. Now, in this graph, you can see on the vertical is the percent of patients, and on the horizontal is the number of T2 lesions that are seen. And in this case, it was in a group of patients that were used and given interferon over 1 year. So we're talking about poor responders and responders. Now, the responders are in blue. So if you have no new T2 lesions, that means that you have a greater percentage of people that are good responders. And you can see in that first bar, it's very few that are poor responders. But as you have more lesions, like 1, 2, and 3, you can see the percentage of poor responders increase. So numbers of T2 lesions are important in indicating if the patient is a good responder. Now, I'd like to take a minute to give the history of MS drug release. And this is a busy slide, but I just want to show you a few things and associate name with the type of drug. And, for example, beta-seron came out in 1993. Early on, we even had a lottery for that, but then the drug became more available. In 1993, beta-seron is interferon beta-1b. It's sub-Q every other day. Avonex came out in 96. It's an interferon, an immunomodulator like beta-seron. It's a beta-1a, and it's IM once a week. Then clopastone came out, a different kind of drug, not an interferon, and it came out in 1997. It's called glutaramine acetate. It's sub-Q daily, and it's an immunomodulator. Then a form of the interferon beta-1a is Brevif. It came out in 2002, and it's sub-Q 3 times a week. So more frequent dosing, and it's a bigger dose over a week period. Divatrone came out in 2006. Mitoxantrone, it's IV, and I'm not going to discuss that much because it has a significant side effect of cancer cells that can occur in the periphery, and it can induce leukemia and other cancer types. Tysabri is a new drug that came out in 2010. Very robust drug, but it is an immunosuppressant. Unlike the other platform drugs, it's an immunosuppressant. Came out in 2010, natalizumab, it's IV once a month. Extavia is a form of an interferon beta-1b, and then came Gilenya. Gilenya was the first oral drug in this new group. It came out in 2011. Fingolimod, it's oral. We give it 0.5 milligrams every day. Aubagio came out in 2012. Teriflunomide, it's oral. We give 7 milligrams, then 14 milligrams Q daily. And Tecfidera came out. It's the newest drug. Came out in 2013. Early on, it was called BG12. Many people do it by that. It's dimethylfumarate. You start at 120 milligrams PO, or by mouth, and you go up to 240 BID. So that's the summary of drugs, and most of those are the drugs that we have today in our armamentarium. How do we have to think about the management or the treatment format in MS? And this is key. Patients have to understand this, doctors have to understand it, but it's something that you really have to have as your foundation of knowledge for the treatment of MS. So first of all, and something I always emphasize, is early diagnosis, early treatment allows greater efficacy and the patients do better. I've talked about that for years. Disease-modifying therapy, or the platform drugs, by and large, is the first choice today. We also need to know in this treatment format to determine